Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine educator. So as a part of the Medicine Challenge 50 days, so today is day 3 of the Medicine Challenge. So we are doing the topics related to the connective tissue disorders. So the today's topics will be systemic lupus erythematosus, Sjogren syndrome, dermatomyositis, and as well as the questions related to polymyositis. So the first question as a part of the Medicine Challenge day 3, it is, which of the following is not an autoimmune disease? Systemic lupus erythematosus, Graves' disease, ulcerative colitis, rheumatoid arthritis. So the answer in this question is the ulcerative colitis. Whereas you take the systemic lupus erythematosus, it's an autoimmune disease where you have the antibody that is anti-Smith. The most specific will be anti-Smith. And in case of Graves' disease, which is nothing but your thyrotoxicosis, that is also an autoimmune disease, and the antibody is thyroid stimulating immunoglobulin, which will stimulate the follicular cells to produce excess amount of the thyroid. Then rheumatoid arthritis. Rheumatoid arthritis is also an autoimmune disease. The antibody in this will be the anti-CCP, that is anti-cyclic citrullinated polypeptide. Whereas the ulcerative colitis, it is the disorder which is caused by reaction to the microbial antigens. So the answer in this is the ulcerative colitis is not an autoimmune disease. Next question. So anti-Rho antibodies, right, are present in all except systemic lupus erythematosus, Sjogren syndrome, neonatal lupus, mixed connective tissue disease. So this anti-Rho antibodies, they are also called as the SSA antibodies, right? And they are present in the SLE, they are present in Sjogren syndrome, and they are also present in the neonatal lupus. So in the neonatal lupus, the antibodies from the mother, it will reach the fetus through the placenta. And what this anti-Rho antibody can do in the neonatal lupus is it can cause the complete heart block. Whereas in mixed connective tissue disease, you don't have the anti-Rho antibodies. And what are the antibodies that you have in case of mixed connective tissue disease is, that is your anti-U1 RNP. So what do you mean by this RNP? That is ribonucleoprotein antibody. That is what is the antibody in case of mixed connective tissue disease, but you don't have the anti-Rho antibody or SSA antibody. Next question. Normal CRP with elevated ESR is seen in rheumatoid arthritis, systemic lupus erythematosus, scleroderma, polymyalgia rheumatica. The answer in this question is the systemic lupus erythematosus. So there are many conditions where you have high ESR with normal CRP, right? High ESR with normal CRP. So you have that in patients with the SLE. Second, you have this in one of the large vessel vasculitis, that is giant cell arthritis. And you see that in one of the hematological malignancy, multiple myeloma. And you come across the same scenario even in case of the leukemia, right? And lastly, you come across the same in patients with the ulcerative colitis. Okay, so these are the conditions where you have the high ESR with normal CRP. Whereas you take in case of rheumatoid arthritis, depending upon the severity, the CRP and as well as ESR, it can be normal, or both of these, they can be elevated also. So either of these can be there in patients with the rheumatoid arthritis. When CRP and ESR both are normal, the score which is given is 0, right? And it can be, both of them can be elevated also in rheumatoid arthritis. And you take in case of the scleroderma. In scleroderma, you will have ESR being normal, CRP gets elevated here. Okay, so CRP is elevated, but ESR will be normal in case of the scleroderma. Whereas you take in case of polymyalgia rheumatica. Polymyalgia rheumatica, it is the one which is associated with the giant cell arthritis, and where you have stiffness of the shoulder and as well as the hip girdle. So in these individuals, both ESR is elevated and CRP is also elevated. Okay, so the answer to the present question now is your systemic lupus erythematosus, where there will be normal CRP with elevated ESR. Next question. Characteristic cardiac lesion in SLE is verrucous endocarditis, valvular incompetence, heart block, myocardial fibrosis. So the characteristic cardiac lesion will be verrucous endocarditis. So what are the other names for this verrucous endocarditis is? It is also called as Liebman-Sachs endocarditis. Right, it is also called as the Liebman-Sachs endocarditis, right? Or it is also called as non-bacterial thrombotic endocarditis. This is the most characteristic cardiac lesion of the autoimmune disease, that is systemic lupus erythematosus. And endocarditis means mainly it is the valvular involvement. So the most common valve that gets affected in patients with the SLE will be the mitral valve, right? Then followed by that you have the involvement of the aortic valve. Okay, so this is about your Liebman-Sachs endocarditis, which is the characteristic cardiac lesion in patients with the SLE. Next question. A young girl is admitted with joint pains and a butterfly rash and a positive urine proteinuria. What is the best test in this patient to diagnose her disease? The options are the anti-DS DNA antibody, the anti-centromere antibody, antibodies to RNP, antibodies to tRNA synthetase. So joint pains, butterfly rash, and positive urine proteinuria, and that too in a young girl. So this is suggestive of the SLE. Now in patients with SLE, like what is the most specific antibody? So one is your anti-Smith, and if that is not there in the option, then you can go with the anti-DS DNA. And what about the other antibodies? The anti-centromere antibodies present in scleroderma, right, where you have stiffness of the skin. And antibodies to RNP, you get this in case of the CNS lupus, right, that is in case of cerebritis. And antibodies to tRNA synthetase, they are associated with polymyositis, right? They are associated with the polymyositis with interstitial lung disease. So the answer in this question is the anti-DS DNA antibody. Next question. So the next question is, psychosis in SLE is caused by the anti-ribosomal P antibody, anti-glutamate acid decarboxylase antibody, anti-endomysial antibody, anti-histone antibody. So the psychosis, it is caused by anti-ribosomal P antibody. Now what about the other options? That is the anti-glutamate acid decarboxylase antibody. It is seen in case of latent autoimmune diabetes mellitus or latent autoimmune diabetes of adults. And then anti-endomysial antibody seen in the celiac sprue. And the anti-histone antibody, it is the antibody in drug-induced lupus. Right, so the answer is the anti-ribosomal P antibody. Next question. Most common presentation of the cardiac lupus. Options are myocarditis, pericarditis, aortic regurgitation, Liebman-Sachs endocarditis. See, in case of the cardiac lupus, what you will have is the pancarditis, right? That is pericarditis, myocarditis, and endocarditis. But out of which the pericarditis, that is the most common cardiac abnormality in systemic lupus erythematosus, right? Now, apart from pericarditis, the other abnormality can be myocarditis and as well as endocarditis. And not only that, even there can be coronary artery disease also. And what is the reason for the development of the coronary artery disease is that is mainly due to vasculitis, right? That is mainly due to vasculitis, right? And it could be also due to premature atherosclerosis. And the other mechanism for the coronary artery disease is the presence of the association antiphospholipid antibodies associated with the SLE. Okay, but the premature atherosclerosis, that is considered to be the frequent cause of the coronary artery disease in patients with the cardiac lupus. So the answer in this question is pericarditis. Okay, next question. The following are the features of the SLE except sterile vegetations on valve cusps, Raynaud's phenomena, atherosclerosis, pulmonary fibrosis. So the one what you don't have is the pulmonary fibrosis. The sterile vegetations on valve cusps, they are the part of Liebman-Sachs endocarditis. Raynaud's phenomena is seen in patients with the SLE and also seen in patients with the scleroderma. And premature atherosclerosis will be there. And what will be the pulmonary manifestations in patients with the systemic lupus erythematosus will be is there can be development of the pleural effusion, right? And there can be development of the interstitial lung disease. There can be pleuritis, and there can be diaphragmatic myopathy causing shrinking lung syndrome. But this shrinking lung syndrome, this is one of the rare manifestation that you come across in patients with the SLE. Okay, the one what you don't see in SLE will be pulmonary fibrosis will not be there. Next question. So lupus anticoagulant is associated with all except recurrent abortions, polyhydramnias, intrauterine growth retardation, preeclampsia, early onset. See, lupus anticoagulant, it is a part of the APLA syndrome, that is antiphospholipid antibody syndrome. Okay, and this APLA syndrome, it is associated with recurrent abortions in patients who are having this APLA antibodies. And almost 50% of patients with SLE, they have the association of this APLA syndrome and they have the recurrent abortions. There will be intrauterine growth retardation. There can be preeclampsia of early in onset. But this lupus anticoagulant, which is a part of your APLA syndrome, is not associated with the polyhydramnias, right? It is not associated with the polyhydramnias. Okay, so second option is incorrect. The question asked is except. Moving on to the next question. All of the following are the indicators for the use of corticosteroids in SLE except neuropsychiatric lupus, pericarditis, endocarditis, nephritic syndrome. So in case of the endocarditis, that is Liebman-Sachs endocarditis, what is that we need to do is you need to do valvuloplasty. Right, you need to do valvuloplasty. So we don't, right, we don't give steroids in case of the endocarditis. So we need to definitely do the valvuloplasty, right? And in neuropsychiatric lupus, pericarditis, and as well as nephritic syndrome, we give this particular corticosteroids. All right. And in case of the endocarditis, whenever there is valvuloplasty being done, what is that you do is, so either you repair or you change the valve completely where we place the mechanical prosthesis. Next question. Okay, so this is almost a repeat question. So corticosteroids are used in all except lupus nephritis, lupus cerebritis, Liebman-Sachs endocarditis, and lupus pernio. So Liebman-Sachs endocarditis, which is nothing but your endocarditis in case of SLE, where we need to do valvuloplasty, but not the steroids. Whereas in case of lupus nephritis, cerebritis, we give this corticosteroids. And lupus pernio, it's a part of the sarcoidosis. Okay, and in sarcoidosis, we give steroids. The drug of choice is steroids. Okay, so the answer is C. Next question. Which of the following antibodies correlates with disease activity for SLE? The options are anti-Smith antibody, anti-dsDNA antibody, anti-histone antibody, the anti-Rho antibody. So the one which will correlate with the disease activity is the anti-dsDNA antibody. Whereas the anti-Smith, if you see, this is the most specific antibody that you see in patients with the SLE. Anti-histone antibody, it is the one seen in case of the drug-induced lupus, right? Whereas anti-Rho antibody, what is this associated with? This is associated with the neonatal lupus, right? Associated with neonatal lupus, where the fetus or the newborn baby can have the development of complete heart block. And this antibody, it is also associated with the photosensitivity in patients with the SLE. And what is the treatment for the photosensitivity that we give is the hydroxychloroquine, and then the sunscreen lotions have to be given. And what percentage of patients with SLE will have the antibody? That is 15% of patients, right? Next question. Anti-double stranded DNA is highly specific for, okay, so it's a straight question: systemic sclerosis, SLE, polymyositis, and as well as the rheumatic sclerosis. So the answer in this question is the systemic lupus erythematosus. Whereas in systemic sclerosis, like the antibody will be anti-topoisomerase antibody, right? Anti-topoisomerase, the antibody. All right. Next question. So the best marker for drug-induced lupus is antihistone antibody, anti-dsDNA, ANA, then anti-Smith antibody. So it is your antihistone antibody. And you should know the most common drug that is responsible for drug-induced lupus is procainamide, which is your class 1 anti-arrhythmic drug. And your drug-induced lupus, you don't have this female predilection. Normally your SLE has the female predilection, but drug-induced lupus, it does not have the female predilection. And once you stop the drug, after a few weeks, the lupus will get subsided. And the antibodies are the antihistone antibodies. Next question. Joint erosions are not a feature of rheumatoid arthritis, psoriasis, multicentric reticulohistiocytosis, then SLE. So in patients with SLE, the type of arthritis that you will have is non-erosive arthritis, right? Non-erosive arthritis. So you don't have deformities in the joints in patients with the SLE. So in patients with SLE, actually the most common musculoskeletal manifestation will be synovitis, right? And because of this, the individual will have the joint pain, right? That is nothing but your arthralgia. So very few patients, they develop arthritis, and that too it is non-erosive arthritis. Okay, so joint erosions, they are not a feature of the systemic lupus erythematosus. Next question. Deposition of the anti-dsDNA in the kidney, skin, choroid plexus, and joints is seen in SLE, Goodpasture syndrome, scleroderma, Raynaud's disease. So deposition of anti-dsDNA, that itself is very much enough to diagnose it as SLE, because anti-dsDNA, it is most specific for systemic lupus erythematosus. Next question. In SLE, the characteristic kidney lesion is mesangial proliferation, tubular fibrin deposition, wire loop lesions, IgG deposits. So the answer in this question is the wire loop lesions. So in case of the kidney, right, we call this as the lupus nephritis, right? We call this as lupus nephritis, and there are totally 6 classes, right? There are totally 6 classes in case of the lupus nephritis, out of which the class 4, this is considered as diffuse lupus nephritis, right? This is considered as diffuse lupus nephritis. So in case of diffuse lupus nephritis, you have the presence of this wire loop lesions. Okay, the characteristic kidney lesions in SLE will be wire loop lesions. Next question. Features of SLE include all of the following except recurrent abortions, sterility, Coombs positive hemolytic anemia, psychosis. See, in patients with SLE, they are associated with Apla syndrome, as we have discussed. They have recurrent abortions, and in patients with SLE, there is autoimmune hemolytic anemia, right? And these patients, they also develop what is called pancytopenia. So there will be anemia, thrombocytopenia, and as well as leukopenia. So Coombs positive hemolytic anemia will be there, and there will be also development of the psychosis. But the one what you don't have in patients with SLE will be your sterility is not the feature of the systemic lupus erythematosus. Next question. Low doses of aspirin therapy are essentially advised for all of the following conditions except rheumatoid arthritis, intrauterine growth retardation, post-myocardial infarction, and then pre-eclampsia. So low-dose aspirin therapy, right, it is not advised in case of the rheumatoid arthritis. See, in rheumatoid arthritis, in acute phase, the drugs that we give is steroids, or we give the NSAIDs, that is non-steroidal anti-inflammatory drugs, right? But in the maintenance phase, we give DMARDs, disease modifying anti-rheumatic drugs. But there is no role of low-dose aspirin in case of the rheumatoid arthritis. IUGR, post-myocardial infarction, and pre-eclampsia, there is role of the aspirin therapy, but not in case of your rheumatoid arthritis. Next question. Primary idiopathic polymyositis does not involve pelvic girdle muscles, neck muscles, ocular muscles, and then the pharyngeal muscles. So the muscles which are not affected in case of polymyositis will be the ocular muscles. So if you take this polymyositis, it is a subacute inflammatory myopathy affecting the adults. And in these patients with the polymyositis, let me tell you, they don't have the following features. That is, they don't have the rash, right? And involvement of the extraocular muscles and facial muscles is not the feature of your polymyositis. And family history of neuromuscular disease is not the feature of polymyositis. And history of exposure to myotoxic drugs like your statins will not be there. Endocrinopathy, neurological disease, muscular dystrophy will not be there in patients with the polymyositis. And inclusion body myositis as excluded by muscle biopsy analysis. So these are the features which are not seen in patients with the polymyositis, okay? And in polymyositis, it is mainly the proximal muscles which gets affected. That is your pelvic girdle and even the other muscles like neck muscles and pharyngeal muscles. But your extraocular muscles and as well as the facial muscles, they are not affected in patients with the polymyositis. Next question. Keratoderma blennorhagicum is pathognomic of the Behcet's, Retter's, Lyme disease, and then glaucoma. So what exactly is your keratoderma blennorhagicum? So keratoderma blennorhagicum, it is the hyperkeratotic vesicles, right? Hyperkeratotic vesicles which are present over the palm and as well as the soles. And you see that in patients with the Retter syndrome, which is also called reactive arthritis. So this Retter syndrome or reactive arthritis, this is characterized by a triad. And what is that particular triad in Retter syndrome is that includes the arthritis, then urethritis, then the conjunctivitis. So this is a triad in patients with the Retter's or the reactive arthritis. So your keratoderma blennorhagica is pathognomic of the Retter's or reactive arthritis. And this particular Retter's or the reactive arthritis, it occurs after a gastrointestinal infection caused by Shigella or Salmonella, or it may occur following sexually transmitted infection, that is your Chlamydia trachomatis. But the most common organism is Chlamydia trachomatis that will be causing your Retter's or reactive arthritis. Next question. Recurrent orogenital ulceration with arthritis is seen in Behcet's, gonorrhea, Retter syndrome, syphilis. So recurrent orogenital ulceration, it is a characteristic feature of the Behcet's. And along with recurrent oral aphthous ulceration, you also have arthritis in patients with the Behcet's. So in patients with Behcet's, it is the HLA-B5 or the HLA-B51. These patients, they have recurrent oral aphthous ulceration. And when we use the word recurrence, how many times it appear in the year? So it almost appear 3 times in a year, right? And these lesions, they are completely the painful lesions. Oral ulcerations, they are painful lesions and they are like superficial. And whenever they heal, they don't have any scar formation. Which one? The oral ulcer. And genital ulceration, if you see, in case of Behcet's, these are less common than compared to that of the oral ulceration. And whenever they heal, the genital ulceration, they form the scar formation. And arthritis is also seen in patients with the Behcet's, okay? And so this Behcet's, it is called oculogenital ulceration. And even the ocular manifestation will be there in patients with the Behcet's, and that will be in the form of the anterior and as well as the posterior uveitis. So that is what you will observe in case of the Behcet's. All right, next question. Lilac colored, that is heliotrope pigmentation over the face is characteristic of dermatomyositis, polymyositis, SLE, systemic sclerosis. So lilac colored or heliotrope rash, it is a characteristic feature of the dermatomyositis. Okay, so characteristic pathognomic cutaneous features of dermatomyositis is one, your heliotrope rash, and the other one is the Gottron's papules. Right, Gottron's papules. Okay, and the one which you don't see in patients with the dermatomyositis. Okay, so the one which is not pathognomic of your dermatomyositis is your malar erythema, poikiloderma. You don't see that in case of dermatomyositis. And violaceous erythema on the extensor surfaces and periungual and cuticular changes is not the feature of your dermatomyositis. Okay, so the answer in this question is dermatomyositis, where you have lilac colored or the heliotrope pigmentation. Right, we'll move on to the next question. All of the following are the features of the Behcet syndrome except the options are recurrent after stomatitis, multi-system involvement, seen only in tropics, common in youngsters. So Behcet's, if you see, there will be recurrent after stomatitis. That is what we have discussed just previously. Multi-system involvement will be there in Behcet's, right? But seen only in tropics, it is an incorrect statement. It is both seen in tropical and as well as the subtropical countries also. And the country most commonly where you come across this Behcet's, it is Turkey. So recently it is called Turkey, and it is common in youngsters. Okay, the one what you don't, which is the incorrect statement, that is except seen only in tropics, is an incorrect statement. All right, next question. Which of the following is wrong about the Sjogren syndrome? Saliva has increased concentration of IgA. Saliva has increased concentration of the sodium. Saliva has increased concentration of the phosphate. Maximum amount of saliva secretion is 1.5 ml in 15 minutes. So Sjogren syndrome is what? It is your Sika syndrome, like where you have the antibodies which are formed against the lacrimal glands and as well as the salivary glands. So the answer in this is saliva has increased concentration in the phosphate is a wrong statement. What will happen to the phosphate levels in case of the Sjogren syndrome will be is it is reduced. Okay, and Sjogren syndrome leads to reduced salivary flow, so that will be less than 1.5 ml in 15 minutes. That is a correct statement. And if you see the normal pH of the saliva, that is around 6 to 7.5. That is a normal pH of the saliva. And the buffer systems responsible for the human saliva, they have the buffering capacity. And what are those buffer systems? That is contributed by your bicarbonate, phosphate, and as well as the protein systems. So these buffer systems, they protect the teeth against the demineralization by maintaining the optimal pH, right? By maintaining the optimal pH for hydroxyapatite. But what happens in patients with the Sjogren syndrome? In patients with the Sjogren syndrome, the value of the phosphate in the saliva is reduced. And that will lead to lowering of the pH and development of the dental caries. So if you see the cytometric analysis of the saliva in patients with the Sjogren syndrome, what are the contents increased? The contents that will be increased is the sodium, chloride, and as well as the IgA. And what are the contents which are reduced in the saliva of the Sjogrens? That will be phosphate, bicarbonate buffer systems are reduced. And the contents which are being maintained normal will be calcium, protein, and as well as amylase. So this is the cytometric analysis of the saliva in patients with the Sjogren syndrome. So moving back to the question now again. Okay, so saliva has increased concentration of the phosphate is a wrong statement. But what did we discuss about the sodium levels? That will be increased. Sodium, chloride, and IgA, all of them are increased. Okay, so the wrong statement is your C. Next question. Drug for the management of the xerostomia: cevimeline, 3,4-aminopyrimidine, neostigmine, and then physostigmine. So cevimeline, it is a cholinergic agent, right? And what it does, because it's a cholinergic agent, it will increase the salivary secretion. and it acts on which receptors? It acts on the M1 and as well as the M3 receptors. Okay, so it is the muscarinic agonist. It's a muscarinic agonist. This increases the salivary secretion and reduce the dry mouth manifestation in xerostomia. And what are the other drugs that can be given is the pilocarpine. Even this will increase the salivary secretion. Okay, right. And you take this 3,4-diaminopyrimidine. It is the drug that we give in case of Lambert-Eaton myasthenic syndrome. Whereas neostigmine and physostigmine, these are the drugs which are given in the treatment of the myasthenia gravis. Next question. Most common lymphoma associated with Sicca syndrome is maltoma, Burkitt's lymphoma, DLBCL, then lymphoplasmacytic lymphoma. So the most common lymphoma in patients with the Sicca syndrome, see, patients with Sjogren's, they have the incidence of non-Hodgkin's lymphoma, right? The association with the non-Hodgkin's lymphoma. And within the non-Hodgkin's lymphoma, like what will be the most common histological subtype? Right? So the most common histological subtype in non-Hodgkin's lymphoma, that will be your maltoma, which is nothing but mucosal associated lymphoid tissue. Mucosal associated lymphoid tissue. So this is nothing but your maltoma. So which can develop in any non-lymphoid tissue infiltrated by periepithelial lymphoid tissue. Okay, and the most common organs which gets affected by your maltoma will be your salivary gland. That is what happens in patients with the Sicca syndrome. And what are the other organs which are affected by your maltoma is, that will be stomach, right? And even nasopharynx, skin, liver, kidney, and as well as lungs. So the answer is A. Moving on to the next question. Sicca syndrome is associated with all except rheumatoid arthritis, midline granuloma, sarcoidosis, chronic active hepatitis. The one which is not seen in patients with the Sicca syndrome is the midline granuloma. So if you take what is called as the secondary Sjogren's, see, the Sjogren's you have primary and secondary. So secondary Sjogren's is the one which is associated with the other connective tissue disorders. What are the other connective tissue disorders associated with the secondary Sjogren's is rheumatoid arthritis. It can also be associated with SLE, and it can also be associated with the scleroderma, right? And sarcoidosis is also association with the Sjogren's syndrome. Now, this particular Sjogren's syndrome, these patients, they get infected with the hepatitis C, right? They get infected with the hepatitis C, which can cause the chronic active hepatitis. And they can also get infected with the HIV, right? They can also get infected with HIV and as well as the HTLV1. So the one what you don't see in patients with the Sicca syndrome is the midline granuloma. All right. Next question. All of the following may be associated with the Sjogren's syndrome except dry eyes, dry mouth, parotid gland enlargement, and then systemic manifestations. So dry eyes, dry mouth, they're the characteristic features of the Sjogren's, and parotid gland enlargement also will be seen, but systemic manifestations are not the feature of your Sjogren's syndrome. All right. Next question. Sicca syndrome is associated with all except midline granuloma, chronic active hepatitis, rheumatoid arthritis, and then scleroderma. It's a repeat question. So the one what you don't see in the Sicca syndrome is the midline granuloma. So these are the questions of Medicine Challenge Day 3. Right? So again, in Medicine Challenge Day 4, you have the topics like the vasculitis and some miscellaneous topics. So please go ahead with the Medicine Challenge Day 4, and then we will start with the cardiology. Thank you very much.